In today's video, we're going over ACL clinical examination. What's going on, guys? My name is Dan Pope, and we also have Kevin Coughlin. We're physical therapists. Like always, we're going through the literature. We're taking out the relevant stuff, throwing the rest in the garbage, combining it with our clinical experience, and giving you the best stuff that we think of anyway. How you doing today, Kevin?
Doing well. I think this is going to be a cool topic because we're lucky to work in a setting where we get to see people sometimes before they go and get imaging, and we try to help them figure out what's going on. We kind of look to the research to see if our tests are valid or not. I think that specifically with ACL, as we'll get into, there are a few tests that have been around for a while, and you see a lot of different, reliability for these tests. So it'd be good to kind of dive in and get going.
I'm ready to dive in and get going. Let's do it.
All right. So what we're going to cover, we have this huge slide with this little text, but
Good.
just try
Keeps
to
your
space it out. Yeah.
keep those eyes nice and sharp.
Right.
Get those followers to really squint. It's good.
So yeah, this is a pretty concise episode. I think we're really going to focus on the tests associated with diagnosing ACL. So we're going to go over the subjective examination and what you're going to hear from the patient, what questions you want to ask to rule in or rule out an ACL tear. We're going to go over the objective examination, so all the basics, but then include a special section on special tests, and then kind of putting it all together for coming up with the accurate diagnosis.
I'm so pumped.
Let's go. All right. So for the subjective examination, Dan had talked a lot in our previous episode on kind of the background of ACL tears, about a mechanism of injury. But just to kind of reiterate that and what some of the studies I was looking at were talking about, is the ACL tear often occurs during activities involving sudden deceleration, pivoting, changing direction, or landing awkwardly. Patients often report a popping sensation at the time of the injury. And as we get into clustering tests, this is one thing that they'll talk about, is if the patient does report a pop, it tends to correlate pretty highly with an ACL tear in conjunction with other things. So not in isolation, but when it's part of a big picture, it is pretty important. So you want to ask, did they feel a pop or hear a pop at the time of the injury? And I would say anecdotally, the patients I have on my schedule now with an ACL tear, they all felt a pop when it happened. So that's something to ask, again, in conjunction with other positive findings. I think it's pretty significant. Obviously, you can have a pop with like a muscle tear or, something like that. But this is something we see. A difference, kind of interesting. I didn't know this much until I was going through more of this research between meniscus and ACL. But kind of a good differentiator, if you're thinking someone has some joint involvement, is the ACL or intra-articular ligament injuries tend to present with pretty immediate swelling in the joint, and that can be within the first couple of hours. So that person might have swelling almost right away, versus the meniscus, we see a little bit of a delay in swelling. So a little bit of differential diagnosis there. If they didn't notice swelling till a day or two later, maybe we're thinking meniscus. But if they had kind of a very quick onset of swelling, maybe we're thinking ACL or another ligament in the knee. And one of these studies was saying that about 70% of patients will present with swelling. So I think if someone comes in and their injury was maybe a week ago, and they're just doing pretty well, functioning at a pretty high level, we might not see swelling. But that's going to be something that they're going to say is, I've noticed swelling in my knee. They're going to report difficulties walking or with other functional activities, potentially having feelings of instability and just a general lack of confidence. Maybe they feel okay with ADLs, but they don't feel like they could do running, cutting, explosive type movements. So these are things you're going to hear and you want to ask for in the subjective exam.
Hey there. Sorry to interrupt, but I've got something cool. It's an evidence-based exercise selection cheat sheet after ACL reconstruction. Sometimes it's a little bit scary working with patients after ACL reconstruction. Obviously, you don't want to hurt them, and the exercises that we choose matter. So I created a cheat sheet to help you out. It goes over which movements have the most strain on the ACL graft and how to dose those exercises from low to high. We use the evidence to guide us so you can make the right decision for your patient after ACL reconstruction. We'll also tackle that age-old question of whether or not you should be using open kinetic chain knee extensions with your patients early on after ACL reconstruction. This cheat sheet is 100% free. I'll leave a link in the show notes in the description below. Go ahead and click on that and get to learning. Now, back to your video.
So getting into the objective examination, kind of like with all our lower extremity injuries, I think it makes sense to start with like a gait analysis. And what we're looking for, like, do they have an antalgic gait pattern? Do they have pain? Are they avoiding loading their quad? Are they using an assistive device? I think these can give us insight before we perform our special tests that, yeah, this person obviously has a intra-articular, joint pathology and something we're going to be testing for. Are they fearful of movement? What's the movement quality and quantity? These are things we can document. We're going to be testing range of motion, which is often going to be limited. I think a lot of times we can chalk that up to swelling. If they do have a bunch of swelling in the knee and we're trying to flex their knee and get a good flexion range of motion measurement, we're not going to be able to get a ton of motion. They're going to feel quite a bit of pain, and the swelling is going to be almost a mechanical block to getting a full range of motion. We also want to be testing extension range of motion. Like we had talked about previously, when we are trying to rehab this thing, regaining extension is very important. And we want to compare that to the unaffected side. So we want to know how much range of motion do you have in the unaffected side? And that tells us how much of a difference there is here. And again, tells us, is this something that we think might be an ACL tear that we're trying to help the patient diagnose? I misspelled swelling, which is pretty embarrassing.
Swelling.
Swelling has two L's. I do know that, but we want to assess swelling. We want to do so with a sweep test, which is when you kind of provide a downward medial pressure to the medial part of the knee. And then you want to go ahead laterally and sweep it back. And you want to see how much swelling goes into that medial compartment of the knee. And we do grade that. So we kind of say if someone has a 3+ swelling, that's the most significant amount of swelling. You're trying to do the sweep test and no fluid is moving at all, versus if we do this test and we sweep it out and it comes back on its own, we call that a 2+. If we go ahead and sweep it out and then sweep it back, and I'm sure Dan will do amazing videos on this in the future for diagnosis. But a 1+ is you have to sweep it back in. And then trace is there's just a little bit of visible swelling that, would call a little less than that 1+. So we're trying to quantify that, something we can track over time. I also think it makes sense to take circumference measurements. So I like to measure at the joint line compared to the uninvolved side. I usually do about 5 centimeters above the joint line, which is that suprapatellar pouch where we do see a lot of swelling kind of hang out. And then I'll also measure halfway up their quad. So for a lot of people, that tends to be 15 or 20 centimeters up above the joint line, and then about 15 centimeters below. So we're looking at the size of their calf and the size of their quad. And that's just good information that we want to get because that's something we can track over time. We know they're probably going to lose strength. They're going to lose muscle mass, and it's good to quantify that. And then if you have the ability to, I think on that first visit, if you're thinking they have an ACL tear, you want to do strength testing on the non-operative or the uninvolved side, because that's going to give us our best strength number for their current level of function. If this injury happened only 2 or 3 days ago, then we know they probably haven't lost much strength yet. And having that number as a good gauge long-term is going to be more helpful than relying on if this person does have an ACL tear and goes on to get a surgery. It's going to be more helpful than that first strength test at like 3 months, because we know the uninvolved limb has gotten weaker. So if you do have the ability to test strength, go ahead and get it, at least on the uninvolved side. I would say I typically don't test strength on the involved side. It depends how much pain they're in. And, is it really going to tell me a bunch right now? If it's pretty pain-free and they feel like they can exert some good force in a safe manner, we'll test it. But I think oftentimes just having the uninvolved side is probably enough to get you through there. So Think before we get to special tests, these are good things we want to kind of quantify in our objective exam to, if this person does go on to get surgery or we try to rehab this thing non-operatively, these are measurements we can always come back to and see how we're progressing over time.
Yeah, I think you nailed it, because a lot of these tests are very important for the diagnosis, but we also want these numbers to help track whether or not you're making progress over the course of time. So, like the circumferential swelling measurements are going to be really good. Like, oh, it's swollen, there's a chance there's an ACL, but also, is this getting better over the course of time? And like you said, we're also measuring muscle mass. Is the muscle kind of getting better? Is it getting worse? Like, what's kind of going on? What's the trend there? The other thing I will say is that we can use those pre-op numbers on the contralateral side, but also the operative side, potentially if you're going to go operative, as a guide, whether or not someone's ready for surgery. So I think that's kind of worth mentioning. So we want to make sure that that pre-op quad hamstring strength is pretty dang good before surgery, because that's going to affect those long-term outcomes. So maybe not visit one, right? But if we know that patient is eventually going to be going into surgery, we want to make sure that swelling is minimal, range of motion is good, and also that strength is kind of back to a degree. And we probably just need to do some handheld dynamometry measurements to figure out if they're ready or not for surgery, not just from a diagnostic standpoint.
Yeah, I think that's a great point. We're using this information from our assessment not only to come up with a diagnosis, but to make our lives easier as we come up with a rehab plan and make sure that we're retesting these things and seeing if we can get the patient in the optimal state for surgery. Because I'm sure we'll get into this when we look at future podcast episodes in ACL surgeries, but I'm sure there's really good evidence that the stronger you go in, and if you do some good prehab, that you're going to get better outcomes. So, that is all good information to get. But getting into kind of the nitty gritty of this episode is figuring out if our special tests are valid and what tests should we perform. Because if you tell someone you think they have an ACL tear, hopefully you have good testing to back that up, because I think it is a pretty significant diagnosis to lay on somebody. And, you don't want to say the wrong thing and say that you think they do, but then they don't, and they lose faith in you. So, looking through this research, I think you see a lot of different things. If you look up sensitivity and specificity of kind of our gold standard tests like the Lockman or the anterior drawer. So I thought this was a cool study because it's relatively new, study from 2023. And kind of special testing forms the cornerstone of the objective assessment in ACL diagnosis. And this study was from February of 2023. And it's called the Clinical Exam in the Diagnosis of ACL Injury, a Blinded Cross-Sectional Evaluation. Getting into the study a little bit, the objective of the study was to compare the effectiveness of different clinical tests for a suspected ACL injury. For the methods, the examiner evaluated and performed the Lockman, the anterior drawer, and the lever test to diagnose an ACL tear. I think the cool thing here is the examiner was blinded to the patient history, the symptoms and the laterality of pain, and at the time of the examination. So they tried to blind the examiner. I think if some of the things we said are apparent, right, they're just going to have swelling, I think you might have a good idea of what side it is. It's not generally too confusing, but I think it makes for a higher quality study. The findings were compared to an MRI, which is kind of our gold standard for diagnosis. I guess underneath arthroscopy, because some of these studies, they would, we'll talk about MRI, but the study would do MRI and then compare that to when they actually went in arthroscopically. And that's where they're really going to absolutely have a good indication of if there was damage to the ACL or not. And they're also actually using this information to see how reliable is our MRI. And that's pretty cool. So the study had 133 patients. The average age was 30 years old, but there was a range of 14 to 59 years old. So just, keep that in mind there. A summary quote here from the study in terms of the findings is that all patients with an MRI indicative of an ACL tear who underwent arthroscopy had intraoperative evidence of an ACL tear. So just before I continue the quote, what that's saying is that the MRI picked up an ACL tear and there were no false positives. Everyone that had an MRI positive ACL tear intraoperatively had an ACL tear. So MRI was really good at picking that up. And no patients were diagnosed with an ACL tear intraoperatively without positive findings of an MRI. So in this specific study, the MRI had 100% sensitivity and specificities. Every person who had one on imaging ended up having one intraoperatively. And once they were kind of in surgery, they didn't miss any. So MRI was very, very good here at diagnosing ACL. And that makes me think, we never hear of someone I've never heard of anyone going in for a meniscus surgery and they say, oh, wow, we didn't know this, but your ACL was torn. But conversely, I do see a lot of people go in for an ACL surgery who had an MRI, and then the doc goes, oh, I didn't, the MRI didn't pick this up, but you did have a meniscus tear. So I know we're not reporting on the sensitivity and specificity of MRI for meniscus tears right now, but it's generally very, very good for ACL tears. So, that's good to know.
Yeah, I think so too, because think of all the times that we have MRIs that come back and they show so much stuff and you're not really sure what's relevant, like in the low back. My dad just sent me an MRI of his spine and he's, upper there in the upper 60s. Like there's all sorts of stuff. And my first thought was like, not bad given your age, but there was like a, 30 line readout of all the different things within his spine, right? Where tendinopathies are kind of same. We find these tendinopathies all the time. Any small partial thickness cuff tears, like, are these even relevant? At least for the ACL, it's a little bit more cut and dry, right? MRI shows this. That's probably what's going on. That's kind of nice,
Totally. So just a little explanation about the studies, the tests used in this study. So like I had said, they used the Lockman, the anterior drawer, in the lever test. One that they didn't use, but I included it because we're going to talk about it in other tests, is the pivot shift. So just, I think, again, spoiler for, I think, Dan's future social media, but I assume he's going to have the best videos ever on these tests with good quality demonstrations, so you can replicate them as good as possible, because reliability here is definitely important, right? So
I'm nervous.
Dude, they're going to be the best tests. I sound like Donald Trump, right?
It's going to be good.
All right, we won't make it political, but all right. So the Lockman test is performed with the patient in supine and the knees bent to about 30 degrees of knee flexion. The examiner is stabilizing the distal femur, and they're providing an anterior force to the tibia. A positive test yields excessive anterior translation compared to the contralateral side. So that's the first test that they did. The anterior drawer is performed very similarly, but this time the patient is in supine with the knee flexed to 90 degrees. So that's the same position where you would do a posterior drawer looking at the PCL. And generally, the examiner will sit on the patient's foot to stabilize kind of the lower extremity there. And then they're providing an anterior force to the tibia. Again, they're looking at the amount of anterior tibial translation. Compare that to the contralateral side. I'm going to jump down to number 4 because the lever test was included in the study that I was just talking about. The patient is supine, and this might be kind of a newer one, I guess, they were seeing in the research, but the patient is supine with the knee extended. The examiner will place a fist behind the proximal third of the tibia, and then with their other hand, they're going to provide a downward force on the distal femur. And a positive test here is that the heel remains in contact with the table. What you would expect is in a healthy ACL, you have your hand underneath the proximal tibia, you push down the femur and the heel pops up. And then the pivot shift test, this test is the patient's in supine with their knee extended. The examiner will internally rotate the tibia, and then they flex the knee while providing a valgus force. And a positive test will yield a subluxation of the tibia. Sounds terrible. And when you watch videos of it, especially under anesthesia, it can be kind of gross to look at. But we're getting some stress on the ACL there. And if it's not doing its job, we see that kind of excessive movement there. So those are kind of 4 standard tests that we'll see and talk about.
Yeah, it's pretty cool. I know that Lenny's been using the lever test more. He actually had a patient the other day with a lever test on all the students and was positive, basically pushing, and then the heel didn't pop whatsoever just because all the anterior, I don't know, laxity, right? Tibia's moving forward, but it's not popping up the heel. So kind of cool to see. my thought, and I generally don't do the pivot shift. And um, I've heard this, and to be honest, I'd love to look at the numbers and hear your thoughts on this, but I'd kind of seen that most of the studies reporting on pivot shift are under anesthesia. So it's like, how relevant is this when someone's actually awake? You know what I mean? It's also
Yeah.
pretty aggressive. You know, if you have a patient that you suspect had an ACL tear and you're just ripping on that knee, um, I don't know. It's pretty intense, but I tend not to use it myself as much for those reasons. But yeah, seems to be a pretty valid test. If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really, my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
Okay, so looking here, we have a couple tables that I took from this study. And I think if you have time to pull up the video and look at these, I think it's really helpful to see or pull up the study. It's reference number 3 in the show notes. So definitely worth looking at, I think. But what they're looking at, and they're comparing these tests to the benchmark in this study, which was MRI. And for the Lockman, the anterior drawer, and the lever, they reported on sensitivities and specificities. And then they went ahead and they gave you a positive predictive value and a negative predictive value. So what we saw is the probably best test here overall is the Lockman. The Lockman had a fairly good sensitivity at about 89% and a specificity of about 98 to 99%. So if you get a positive test with the Lockman, it's really good at ruling in high specificity and pretty good sensitivity. A negative test, we're sitting at almost 90%. So the positive predictive value with that positive test is 97%. And the negative predictive value with that negative test is 94%. So pretty good test there, the Lockman. Next with the anterior drawer, a little worse sensitivity than the Lockman. So sensitivity was down to about 62% for the anterior drawer. Specificity was very similar as the Lockman, about 98 to 99%. And the positive predictive value is up to 97%. And the negative predictive value is about 82%. So then the kind of least impressive test of the 3 here was a lever test, So the sensitivity for this test was 44%, and the specificity was 88%. That left a positive predictive value of about 69% and a negative predictive value of about 73%. And then this study didn't include the pivot shift. So it was those three that they were looking at. But I think important to note this next table, table 3 here, they're talking about what if we cluster these tests together. So what if you have a triple positive, you have a positive Lockman, a positive anterior drawer, and a positive lever. And they were saying that they had 14 patients in this study with a positive test on all three of those maneuvers. And the physician, all 14 were diagnosed with an ACL tear by the examiner. And then the MRI confirmed that all 14% had an ACL tear. So in this study, if you have a triple positive, there was a 14 out of 14 success rate. I think it's important to note that the physician who was the examiner was very experienced clinician. So I think the examiner's hands probably matter somewhat, but keep that in mind. Now, if you have a double positive, so 14 patients were also presenting positive with a Lockman and anterior drawer. Those are two pretty good tests. So 14 patients there. And with that double positive, 14 were diagnosed with an ACL tear by the examiner, and all 14 also had a tear under MRI. If it was just the anterior drawer and the lever, if it was the Lockman and the lever, only 3 patients had positive for just those two with a negative anterior drawer. So, I think the theme here, I won't go through every single one of the combinations, but the more tests that are positive, if you have all 3, with this smaller sample size of 14 patients and a very experienced examiner, we had a pretty high confidence that they had a tear, and then the MRI confirmed that. So I think, like most of our special tests, if we can cluster, we're feeling more confident that this person probably has an ACL tear. And then we're going to let the MRI be the ultimate arbiter there. So what do you think, Dan? Are they special or no?
Super special. This is good. I think they provide a lot of good information for us, right? I think it's always tough, right? Because the patient comes in, they had this, kind of catastrophic traumatic event. It's very scary. Oftentimes these patients are very guarded. And I think one of the things that's tough is that you do these tests and you're not sure if the patient's just really guarding and you're getting accurate information from the tests. So it's good to see that they have decent specificity, sensitivities. Kind of nice to know the Lockman is kind of number 1, which is really cool. Stinks to know the anterior drawer is not very sensitive. Same thing with the lever. So one of the things that's a little bit challenging is that I wish we had better sensitive tests, because as clinicians, we're trying to make people feel good, right? And just rule these things out. So if you get negative tests, we want to make sure they have a high sensitivity, because if it was closer to 100%, if there's negative, we're like, oh, good, you're fine. But we don't have a lot of sensitive tests. It's the opposite. We have more specific tests. So we can basically give people the bad news if they're positive. But if they're negative, we're kind of like, I'm not sure. You got to go see the doctor. But I guess if we lump them together, and we've got a bunch of these that are negative, it just increases our accuracy. And like you said, it probably does have a lot to do with the practitioner experience. I'm throwing my wife under the bus here, but she's a family physician. And then sometimes she does try some of these tests on her patients, and she's always like, I have no idea. I don't know if I'm doing these right. You know what I mean? And when you have a new kind of green physical therapist that has never seen a patient after what seems like an ACL tear, kind of the same deal. You're not really sure. You're not sure if you're doing the test right. Someone who just injured their knee, that knee feels a lot different than your classmates that are healthy. You do it on in class. So I think you're right. Probably has to do with the experience of the clinician. I know that in Champion, we often have a lot of people feel the knee, right? Ends up being this whole situation, like, oh, you feel this knee over here? Let me know what you think, right? Which I think is good, but probably freaks out the patient a little bit.
Yeah. Well, one thing I'll say quick, I did skip this part, but to your point about sensitivity and if we cluster them, in this study, 69 patients tested negative with the Lockman anterior drawer and lever, so negative for all 3. All 69 were diagnosed by the physician as having an intact ACL, so they thought they didn't have a tear. And there were only 2 that ended up having a tear. So 97% they were right on 97%. There were 2 that did have a tear. So, it is important to keep in mind that isn't perfect, but it is pretty good. I think if we use it in combination with all the other uh, objective exam findings and with all the other subjective reports, maybe we can paint that picture and get even a little bit better. But that is pretty good. I think we could hopefully, if we run those 3 tests at a high level of implementation, we do them right, that we could be fairly confident they don't have one. But yeah, none of the tests in isolation seem to be amazing at ruling out. Okay, so putting it all together, we have another study here that I think is good because this study is talking about combining what we see in the subjective examination with what we're seeing in the objective examination. So that last study was really just looking at objective clinical tests. So this is a prospective diagnostic study. The title was Clinical Diagnosis of Partial or Complete ACL Tears Using Patient History Elements and Physical Exam Tests. The individuals were over 18 years old and they were seeking help for knee problems. And like I said, the objective was to combine patient history with the physical exam and see if they could predict who has an ACL tear versus another knee issue. So, okay, the table's a little bit small here, but I do think this is totally worth pulling up if you do have the video playing, or if you could check out the study, because this is more real world where we're combining all the information. So the variables that they were looking at with a partial or complete ACL tear, the variables in the patient's subjective history were an absence of a fall or an absence of like a physical trauma, like they fell and they hit their knee. So I think we're thinking more a little bit non-contact. So in the patients who had an ACL tear, that was one finding. One is a history of pivoting on the knee to cause the initial trauma. We did talk about this a little bit, but reporting a popping sensation was a variable that was pretty consistent with an ACL tear. And no or only monthly knee pain. So a lot of times I'd say this is true in the clinic, is these people have the injury and then a lot of times the pain goes away relatively quickly. Like they're not in a ton of pain if you have a complete ACL tear. It's more a feeling of instability. And in these folks that also, the physical exam findings were a Lockman test that was positive and a pivot shift test that were positive. So they were combining all these elements. The variables that were associated with a complete ACL tear only, so not a partial tear, was 3 to 4 weeks of pain at the time of the consultation, an absence of a fall on the knee at initial trauma, so same as the partial or complete tear, a history of pivoting on the knee with initial trauma. They can't pursue their normal activities anymore. They report like, I can't play soccer anymore. I can't do my sport. They have immediate swelling in the knee after the trauma too. So I think sometimes when we don't see swelling, maybe that's someone with a partial or an incomplete tear. But if we do see swelling, maybe that's someone with more of that complete tear. And they also have a positive Lockman and a positive pivot shift. So then looking at the table below here, what the authors were doing is they're chunking the sensitivities, the specificities, the negative likelihood ratios, and the positive likelihood ratios. And if they're looking at kind of pivoting traumatic mechanism, so someone who has a pivot twist type injury, they're seeing a sensitivity of that in isolation of 79%. That's in a partial or complete tear. But a complete only, the specificity, the sensitivity is a lot higher, 95%. If we look at the specificity now, so ruling that in, a partial or complete with a pivoting twist mechanism has a specificity of 84. All right. And then, Dan, let's go to the next slide because they kind of chunk all these things together. So I won't go through these tables too in depth. I think it's totally worth pulling up the study and kind of looking at these. But if we put it all together, what this study showed that I think is really useful is that if we have a combination of subjective findings that don't have a popping or a pivoting mechanism, and we're getting some negative tests, we have even more confidence that they don't have this ACL tear. Conversely, if we are getting some of these positive tests and they're in combination with swelling or feeling like a pop or pivot sensation, then we're we're getting pretty confident that that they might have an ACL tear. So I think, we get some pretty good tests at ruling in. And if it combines with a positive history, we feel pretty confident. And then we don't have the best test at ruling out, but I think if we put the whole picture together, I think what this study kind of showed is a combination of subjective findings and negative testing. We feel a little bit more confident that they don't have it. And at the end of the day, you might just try some rehab anyway before they go to a doctor while they're awaiting their MRI. And then that's kind of, like we talked about earlier, we can be fairly confident in the results of the MRI for kind of ultimately ruling this thing in or ruling this thing out. So I think that's a pretty good study. And I think these tables are pretty useful. So if you go to the study and check them out, I think it's worth looking at.
Cool. Yeah. And just to summarize, it kind of seems like just with our special test based on the other study, we're pretty specific. So if we have a positive test, we're like, probably an ACL, or we cluster them together even more so. And then for the sensitivities, the Lockman's pretty dang good. It was like 88%. The other one's not quite as good. So we may miss some of these. But based on the other study that you just mentioned, if we have some of these negative subjective complaints, so no pop, plus we also have negative special tests, pretty dang sensitive. And I think at the end of the day, if I have a patient that comes in that's got a history of a pop, and they have swelling, and they have some positive tests either for the ACL or some of the other ligaments, right? Like maybe a PCL, LCL, maybe some meniscus pathology, I'm just going to send them to the doctor anyway, because we want to make sure we're not missing something. And you didn't mention this too much, but sometimes like an ACL kind of behaves a little bit like a meniscus or vice versa. So if you're thinking that it's something within the tibial femoral joint, there's swelling, some traumatic mechanism, probably going to send back to the doctor anyway. But like you said, you're going to start with physical therapy. It's not like you're going to hurt them by starting physical therapy. You don't have to stop in the tracks and send them and not come back until, you get some answers. But we can get a better idea of what's going on, and we can kind of get them started regardless. All right, so now you know how to clinically examine ACL injuries. You still need to know the basics about ACL injuries. And I have the perfect video for you. The video is now appearing magically over Kevin's head. And once you click on that, we'll go over everything you need to know about ACL injuries. We'll see you there. If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.